The background on this is I moved to Virginia about 6 years ago and had lived out west for 20 years before that, and was really struck at the extent to which patients with myasthenia gravis were suspect to healthcare disparities. And fortunately, argenx was willing to work with us in sending the survey that went out to U.S. neurologists, and we had 150 respondents who met the enrollment criteria, being that they were board certified, had been in practice long enough, and cared for a sufficient number of patients with myasthenia gravis to really speak to this. And so they were able to provide really helpful insights in two different areas. One is access to care, so the impacts of social determinants of health on access to care. And the second is access to therapeutics. And so the data was actually pretty impressive. The patients, and of course they're responding about the patients that they serve. So this didn't go to patients, it went to neurologists. But they told us about their patient population, and so the distribution of their patients from a racial perspective was actually very diverse. There were, I think, 42% were white non-Hispanics, and 20% were African American, and about 14% were Hispanic. So a pretty diverse patient population. And the results were actually not surprising and discouraging. Opportunities abound. About 90% of the respondents felt that financial hardship was a major driver for healthcare inequities and disparities, and about 50% identified race and ethnicity as a driver of healthcare disparities. Clearly, the perception that there is an issue in terms of access to care, so over 70% of respondents felt that their patients who were facing social determinants of health challenges had difficulty getting to appointments or were more likely to not show up for appointments, and about half identified a prolonged period between diagnosis and symptom onset, or a more prolonged period in patients who are subject to SDOH stress, and interestingly, more likely to be diagnosed with myasthenia gravis as an inpatient during an inpatient crisis, as it were. Not surprisingly, similar sorts of data in regards to access to therapeutics. Interestingly, the neurologists who responded felt that their patients who had SDOH challenges were no more or less likely to have difficulty in getting approval from a payer for thymectomy. However, large majorities felt that for every single other therapy that was queried, so FcRn inhibitors, complement inhibitors, and even IVIG, patients with SDOH challenges were much more likely to face difficulty in getting access to those therapies, to the 60 to 70% response rate. They actually identified drivers of this on both posters, both kind of sets of questions, access to care and therapeutics, and drivers are really, some of them were self-evident, cost being an issue, health insurance being an issue, but also just the ability to travel and access medical expertise and access therapeutics. So concerned that patients' inability to drive or get transportation to clinic was an issue. Other drivers that were thought to be relevant, particularly in terms of access to therapeutics, was a low level of trust in the healthcare system. About 10% of neurologists thought that that was a driver. I would posit that if 10% of neurologists thinks that's a driver, I bet a lot higher percentage of patients think that that's a driver. Health literacy issues as well. Interestingly, we did find that African Americans and Hispanics were much more likely than white patients to have unplanned hospitalizations for myasthenic crisis, which sort of fits with these data. What was interesting is we asked for ideas. What can we do to address these? And the ideas were ranged from things that are fairly straightforward. We need to find a better mechanism to pay for medicines for patients and address the financial toxicity of medicines. But there were also suggestions regarding prioritizing home infusion. How can we treat patients in their home? How can we create better educational opportunities for individuals who are in primary care to recognize myasthenia, be knowledgeable that there are effective therapeutics, and then refer them earlier on during their course for therapy. So at the end of the day, I think the data were a bit discouraging, but we know where we are, or we think we know where we are, and there's certainly opportunities to use this as a foundation to better explore individual drivers, and I think really to get to the patients and understand their perspective.